The recent financial crisis in the U.S. unleashed a passionate debate on the absence of sufficient regulation to protect the interests of Americans. But as regulations associated with health in America well illustrate, it's not enough to just have regulation. You have to have the right type of regulation at the right time, and it must be enforced. Case in point, lead poisoning. A bit of history. In 1908, an Australian scientist first recognized an epidemic of lead poisoning in children. It took European nations just 1 year to make a connection with lead-based paints and to ban their use. Australians verified the connection in medical journals in 1912. But in the United States, it would take nearly 70 more years to ban lead in paints, due mostly to the effective lobbying action of the Lead Industries Association. As the group's president boasted in 1984, quotes, "Our victories have been in the deferral of implementation of certain regulations," close quotes. Once the weight of the facts and the actions of other nations drove regulatory bodies to action, those actions were still painfully slow and agonizingly incremental. Take, for example, the definition of lead poisoning in the United States. In 1970, a blood lead level of greater than 60 micrograms per deciliter made the diagnosis. 1 year later, the level was dropped to 40. It would take 7 more years to drop it to 25, and it wasn't until 1991, 21 years later, that we reached the current level of 10 micrograms per deciliter as the definition of lead poisoning. Large portions of the U.S. population benefited from the new regulations that banned lead paint and progressively decreased the amount of lead in our gasoline. In 1970, 88% of all U.S. children under the age of 6 had blood levels above 10 micrograms per deciliter. By 1991, only 5%. Even so, significant numbers of children are still affected. A study from 1999 to 2001 found that 430,000 kids, or 2.2% of the population of kids under 6, had lead poisoning. The numbers were higher among poor kids, with rates topping 6% in one Medicaid study. Also, lack of proper follow-up post-diagnosis was extremely common. A study published in 2005 found that out of about 3,600 Medicaid-enrolled children in Michigan with lead poisoning, 46% didn't receive appropriate follow-up. Even when we make the diagnosis, we're largely ineffective in basic follow-up because of the weak linkages between health clinics who make the diagnoses and the public health professionals who are charged with treating confirmed cases and advocating for regulatory processes that address issues such as lead poisoning, asthma, safety, and now bioterrorism on a population basis. It's not that we're disinterested, but rather disintegrated and conflicted. The study of lead poisoning illustrates that failed leadership in health can carry extraordinarily high long-term costs. Lead poisoning in children has a well-established association with reading delays, school failure, delinquency, and criminal behavior, independent of other associated risk factors. And as the affected kids turn into adults, the picture worsens. We now know that lead-poisoned children become chronically ill adults with high rates of cardiovascular disease, kidney disease, cognitive decline, spontaneous abortion, tooth decay, and cataracts. As pediatric and environmental health expert Dr. Bruce Lanpher stated recently, quotes, "Lead toxicity may underlie some of the prevalent health disparities found in socially disadvantaged children," close quotes. What are the lessons learned? First, we're way too slow. Second, we're very risk averse. And third, we too often stick our heads in the sand. And whether it's our financial sector or our healthcare sector, we're now painfully aware that when you behave this way, disasters will always be just around the corner. For Health Commentary, I'm Mike McGee.